Good morning, everyone. Welcome to this panel discussion titled Breaking Barriers, Ensuring Equitable Access to Effective Mental Health Treatment for All. My name is Ryan Mundy, and I am founder and CEO of Alchemy Health, and we are a virtual outpatient therapy platform dedicated to providing culturally aligned therapy to the Black community and also providing content-based resources. And I would like to take a moment to have our panelists introduce themselves before we get started. So we'll start with Nisha.
Hi everyone, my name is Nisha Desai. I am co-founder and COO of Anise Health. We do culturally responsive mental health care for Asian Americans. What that means is we've essentially designed a very intentional and unique care model that integrates psychotherapy with behavioral coaching and digital resources, all which are packaged into personalized care plans that are tailored for Asian Americans and delivered by providers who are trained in cultural sensitivity.
Good morning, I'm Dr. Ayo Gabbing. I'm a board-certified child, adolescent, and adult psychiatrist by training, and I also see youth in juvenile detention. But on the other hand, I'm the Chief Medical Officer and Regional Vice President at Humana Healthy Directions. That is the arm of Humana that has a Medicaid growing business. And we also have areas of the company that's Medicare Advantage and commercial business, but my national and state priorities are mostly Medicaid. Thank you.
Hi, good morning, everybody. I'm Joe Paracupta, I'm the CEO of Free Spirit. And at Free Spirit, we're really focused on addressing some of the huge inequities in healthcare, specifically access to healthcare for those individuals who don't have appropriate access. And we do that through our at-home behavioral health solution with FDA indications for panic disorder and PTSD. And we've really taken a unique approach where we combine a medical device with high-touch support to provide individuals with rapid but long-lasting symptom relief that they can all do at home in just 28 days. And our goal is really just to tear down the barriers that so many individuals in this country face with trying to get access to mental health care.
Bukata Hayes, Vice President for Racial and Health Equity and Chief Equity Officer at Blue Cross Blue Shield of Minnesota. One state blue plan that has membership across the country in various lines of business, Medicaid, Medicare, commercial, others. My job is to sort of work throughout the enterprise to uncover and discover ways in which our members are not able to access care, work within the enterprise to fashion solutions for that, deploy those, sort of measure, work across the enterprise to see if we can permanently, if you will, get rid of some of the access access barriers, inequities that we are seeing. So excited to be here.
Cool. Thank you all. And just a little bit of housekeeping and level setting before we dive into our conversation. For this session, mental health.
Good morning, everyone.
We will be excluding substance
Let's
use.
try that one more time.
Just specifically talking about
It is
mental
early,
health, without
but I think we can do a
referencing
little better
substance
than
use.
that.
And then also,
Good morning,
additionally,
everyone.
Just want to set some context around equity and
Nice
also
job.
equality. And here's a metaphor.
My name's
for you.
Casey
Think
Kelly.
about
I'm the Chief
equality
Innovation
and equity
Officer
like giving
of the
everyone
Meadows
a
Mental
pair
Health
of
Policy.
shoes. Equality gives everyone the same size shoe, regardless of fit, so that everyone has access to a pair of shoes.
Programs
Equity, on
at
the other
the state
hand,
and federal level.
makes sure that each person gets
I'm delighted to be
a
here
shoe that fits
facilitating
their
this
size
panel, and I hope
their
you guys
needs.
realize that you are
And
in
so,
for a
again,
treat.
equality and equity matter, and
Just
they're
want to
both
say thank
different,
you to
and they
Behavioral
both,
Health Tech
make a
and
huge impact
to
on the
Brightside
lives of
for
individuals
inviting me to
in which we're
facilitate
looking
the
to
panel.
serve.
And
so let's
I'm
kick off
really
with our
looking
first
forward
question.
to hearing from these great experts today
What current
about such an important topic.
What are the current systemic barriers you're seeing in your work?
In case you can't
or
read
have
the
you faced
screen,
in seeking your own care? And Alicia,
today
we'll
we're
start
going
with
to
you.
talk about bridging the gap,
So there are a
leveraging
lot.
technology to
I'm going
treat
to talk about one
high
that
severity
I've experienced
mental health
firsthand,
needs.
growing up as a child of immigrants, which is stigma. There's a lot of stigma against mental health, seeking mental health care in communities of color.
Folks are aware
in my
that
household,
sometimes
what that
that
meant
conversation
was,
can be
I
upsetting
was often
or
told that
triggering.
emotions that
So
I had
feel free
as
to get up
a child
and,
were a sign of
leave
weakness.
if you need
and
to,
I was
but
told
we
by my
are
parents to
we
be
are
tough,
excited about the
to
topic
get over
and
it, whenever
look
I
forward to talking
wanted to
about
seek
the
help.
solutions
And
involved
ultimately for me
in
that meant
identifying
being
folks
really
who may be
bad,
at risk
really
and may be
bad
struggling.
at seeking help, and definitely not professional help.
So effectively,
And it wasn't until
treating
college where
the most
unfortunately there
severe
was a big mental health crisis
cases,
on my campus,
including those that may be at
where
risk of
unfortunately there were
suicide,
14 people
is really
who committed
key to
suicide,
solving some of our most
and almost
complex
all of those
mental
folks
health
were
challenges that we have
BIPOC
across
individuals.
the country and across
almost
the world.
all of those BIPOC individuals were Asian
and these
Americans.
include populations who may
And,
not have
that
access
really hit close
to a
to
lot of
home for me
resources.
because it made me realize that I had to reckon with the reality of the devastating long-term impact of untreated mental
Care
illness.
is not always available
because of a lot
to
of the stigma
populations
that
most
is
in
carried
need.
in our communities.
And so we're also going to talk about the ways that
as I kind of take that
tech-enabled
back to a
solutions
macro lens, now
might be
working
able
on
to
Ames
help
Health
extend our
and
workforce,
seeing that similar type of
optimize our
story being
workforce,
carried in a lot of the patients that we
and
treat.
bolster the overall
It's very
ecosystem.
evident to me that there's severe
To make sure that more people
underutilization
have access to
in communities of
high-quality
color.
care when and
Speaking for
where
Asian
they need it.
Americans, we are the least likely of all
So
ethnic and
I'm going to
racial
introduce
groups to
each
seek
of our
mental health services,
panelists
and that is
so
for
that
due in large part
you know
to
a little bit about the depth
stigma
and
that
breadth
is
of
carried
expertise
that
you have
leads
here
to
on
low
the
baseline
stage.
levels of awareness.
So
It
first we
leads to
have,
low resource sharing
actually, I
amongst
told you
the
guys you could sit wherever
communities
you want.
around how to even get started with mental health care. And in order to preserve kind of family dynamics around
Health Director of
collectivist
Independence
cultures that
Blue
we
Cross.
come from, a lot of people are kind
And
of delaying treatment
there
until
she is
conditions
focused
really worsen,
on access to
which
quality
can cause a whole
care,
nother suite of
measurement
issues
and
around
value-based care,
diagnosis. So
program development,
there's a lot there,
and program
but I think a lot of that
partnerships.
stems from stigma. And
Next
I
to
think
her, we have
acknowledging,
Brad Kidrich,
this
who's the
fact
CEO and co-founder
creating tailored
of Brightside
solutions
Health.
around addressing that stigma.
Brightside Health,
is one step in the right direction.
in case you're
towards
not
getting
aware,
people the care
is
that
a
they need.
national telepsychiatry platform that supports over 130 million
Because I
lives
wear a couple
across
hats, I have the
commercial,
unique
Medicare,
opportunity of
Medicaid,
being
and
a
exchange
practitioner
plans,
and seeing patients
specializing in underserved
communities,
and
in the
hard to
justice
treat
system,
populations.
as well as administrating healthcare benefits for that same population. So I'm not only seeing them and treating them and doing the actual work, I'm also trying
Leading
to look at
health-
policy and legislative.
Kara is a leading health scientist championing mental health access and
keep abreast of
reducing
those.
stigma
And so
in
from the
high-risk
first perspective,
communities
as a
to drive
practitioner, what I
impactful
see,
change
even in med school,
and improve
residency,
behavioral health outcomes.
practitioners are expected to think.
And then rounding us out
We have to think
is
about
Dr.
do they have
Caroline Carney,
diabetes? You know,
who's the
have they
president
had
of Behavioral
brain
Health
injury? Like,
and Chief
what does
Medical
that
Officer at
mean for my
Magellan.
treatment? But
Magellan is an
unfortunately,
organization
when
providing
you're in
clinical
primary care
programs
specialties, and we have a
directed
specialty for
at the
everything
country's
nowadays,
behavioral health
right? Like if you have
needs
allergies, there's a person.
and
If
management
you've got rheumatoid
services
arthritis, there's a
to health
person.
plans, states,
Which is great. You want there to be
employers, and federal
specialized care
agencies.
and someone
Can
who
we just
is the
give a
best
quick
who
round of
knows
applause
what
for
you
our
need,
our
but
panelists?
They also have to think back to the body as a whole. You know, there's not just walking knees. There's not just allergies without triggers to the whole body. So I think what I see is that we really need to teach
I'd love
that
to hear
integrative
from you
approach
all just a
earlier
little bit
in
of level
care,
setting
right?
about
You
the
can't
current
wait
landscape
until
for
we're already
individuals with
practitioners and
severe
do
mental
CMEs
health
on cultural
needs.
competency. You
Cara,
gotta
could
start
you
day one in
kick
med
us
school
off
saying all of
and
this is
speak on the
important.
state of
In
care for
residency,
those
all of
facing
this is
complex
important. And not just
and
doing
acute
a behavioral health
challenges?
rotation, doing
It's
that
always
work
good.
and integrating that in the curriculum. And I really think that needs to change, and that will bring the humanity back to healthcare, because I think we're losing humanity a little bit in healthcare, and we're thinking about the body in pieces. As a healthcare administrator, I see a lack of resources for mental health treatment, innovative mental health treatments, and behavioral health providers are left scrapping for grants and, you know, trying to do startups and being independent, but they don't have the best EHRs, or they don't have the best text messages, right? When I go, they don't always text me that I'm coming, whereas my primary care provider, I'm like, I get it, I'm coming, right? I got all your emails, I've got your texts, I'll be there. But we really have to look at the system and empower practice transformation for independent providers, whether they're doing art therapy or whether they're doulas for maternity mental health. I mean, we have to empower all of these providers to have the latest and greatest technology to ensure that we're reaching everyone and getting them engaged in the healthcare system.
Yeah, so first I want to thank Nisha for sharing her personal story, because I think that's what we need if we're going to actually encourage others to engage in care. We need to make sure that they feel comfortable. And when hearing stories from individuals, from your community, from your backgrounds, really will propel people forward. You know, at Free Spirit, we're really focused on, again, access to care. And what we've seen in our experience over the last 10 years is access to equitable care and mental health care is a real issue, and it impacts a diverse group of individuals in this country. We've seen it regardless of background and socioeconomic status, but there is a clear disadvantage for underserved communities, and the imbalance is really strong. Our approach is obviously, well, I mean, let's take a step back, and I think it's important to really level set this. 50% of Americans currently live in a designated mental health provider shortage area. So what does that mean for those individuals? They face two potential options. Option one is a very long wait time to get an appointment with a behavioral health specialist. And in those underserved communities, if they're lucky to get one, it's months, not weeks. Number two, and the more likely and unfortunate reality for them, is there's not a behavioral health specialist that's even there to serve them in that community. So what does that mean for them? And that's where we think digital mental health treatments can really provide an opportunity to fill in some of the gaps in coverage. And allowing individuals to access a validated treatment that they can do in the comfort of their own home will also help address some of the stigma issues that you all raised here earlier. But I think what Ayo said was really important, and I think it's a catchphrase that we talk about integrated healthcare, but we haven't really embraced it wholly yet. So when we look at mental health, right now 30 to 50% of individuals with a mental health disorder also have a chronic comorbid illness that goes along with it. So the need to address that mental health issue earlier in the spectrum is so important. And I believe personally, and this is just my own opinion, so I'm not trying to offend anybody, but I think we have to begin to shift the mindset in this country from where we're focused on standard of care as the first option, and in parentheses, often the only one provided to that patient, and embrace a different philosophy where we believe that early intervention with a treatment that meets the patient's needs should be the absolute priority, because it's the only way we're going to get ahead of this.
Yeah, I would say, building off of what has been said, I do think one of the systemic barriers, and you mentioned it, is simply the lack of providers, right? So if I want a provider who looks like me, has lived experience and the technical expertise, I typically have a hard time finding someone like that, right? Which is one of those systemic barriers of how do we increase the pipeline? How do we increase providers? How do we increase sort of what folks would consider cultural concordance in care, where we have this lived experience matched with technical expertise that could sort of relate to me. We find that it increases adherence to treatment plans, better member satisfaction, and a whole host of other things. And so I think that's one of those systemic things. The other thing I think was mentioned too earlier is this idea of what I'm going to say, and I'll mention some of the things around sort of different interventions, this idea of the over-medicalization, right, of mental health and healthcare, that it's like you always have to have some sort of medication. You also have, like, and some of it is simply, so there's a provider in rural Minnesota. There's an article about him, and he's talking about mental health provider, talking about folks suffering from social isolation. And what, in parentheses, he prescribed was connection. Go and be in space with folks. Go and connect with folks to address some of the mental health sort of manifestations that you're dealing with. And what I often think about, and what I'll say is, like, would that be part of the healthcare ecosystem about how we pay for that? If somebody said, hey, go connect. We started to do some of that. If we think about silver sneakers and some other things that but like we can do more. And I think that's such an important piece, is that like the over medicalization of it has went to sort of standard practice or best practice, and forgotten that like some of it is outside of what medically is happening and what is socially, sort of individually, personally happening. And then the last thing I would say is one of those systemic barriers that we see in Minnesota. We have a large rural population, 52% of our membership resides in rural, and it's just the infrastructure in rural parts of our country that don't allow for access to effective care, in particular around mental health. And that has to be something that we focus in on as we try and, one, for us in Minnesota, work across our state, but I think for us as a country, continue to work across this country in spaces where folks who need the intervention, who need the assistance, who need access, are simply unable to get it because of there's no infrastructure that allows for that transmission. So those would be some of the systemic barriers I would see.
Thank you all for sharing. And we led with the title of this panel discussion around like breaking barriers. And in my eyes, it's a two-step process. We're talking about access, but we're also talking about like the effectiveness of care. And to set some context, that's something that I experienced on a very personal level as well. My background and experience is in athletics, former NFL athlete, transitioned out of the NFL, and at the age of 31, found myself with resources, but lacking effectiveness of the care that I was receiving specifically from the lens of like cultural competency and identifying as a Black man, et cetera, et cetera. And so talk about a little bit, not only about the access problem, but more so about the access to effective care. And really, in your own words, what does effective care mean?
Go. Yeah, I feel like that's been a bit of a theme that I've taken away already from this conference. There's been a lot of conversation around like finishing what we started. Okay, first wave of innovation created access, but that clearly is not enough. We shouldn't stop there. Now we need to create effective access. What that means to me is kind of piggybacking a little bit off of what you were saying, Bukata, which is that the standard of care that we are currently relying on is, we're kind of shooting ourselves in the foot if we are relying on that to deliver effective care. And what I mean by that is, if we look at the models of care that we're practicing off of, a lot of them are Eurocentric in nature. If we look at the clinical data that went into developing, the clinical trial data that went into developing these models, it's actually less than 0.1% representative of Asian Americans. So how can the kind of frontline, second line, third line treatments possibly be effective if it was not built for people like me? And so at ANIS, what we are trying to think about is how can we create personalized treatments for the individual that actually target the nuanced intersectionalities and stressors that I experience, people like me experience. And I'm going to just keep going with the personal examples to try to bring some color to this. An example of what I mean by this is for myself. I experience a lot of pressure around being a South Asian woman, which means I face a lot of pressure currently to start a family instead of building a company, being a female founder, because that's what generations of women did before me. They prioritized their family. As a student at an elite college institution, I often felt less than because of the perfectionism that was really instilled in me by tiger parents. And now more recently, as I'm navigating kind of more complex conversations with family members, I have a lot of difficulty relating to them when I hear internalized racism, classism, things that come from generations of trauma that have been passed down from my ancestors. And these are all very nuanced feelings that require nuanced care from the provider that's delivering it, and without acknowledging that the standard of care might not acknowledge all of these intersectionalities and nuances, it's really hard to deliver that effective care. So I believe that effective care really relies on training clinicians to understand these lived experiences, regardless of their own ethnic background, and equipping them with the tools to treat these populations and these intersectionalities. So that we can kind of stop relying on the one-size-fits-all as an excuse for care.
And so kind of piggybacking on that a little bit, when we think about how do we get things done broadly, we generally think of our government, right, or a system, like something bigger than us that has to happen. And I think with MAPIA, they started a conversation. So that's the Mental Health Parity and Addiction Equity Act, mouthful. And that was passed in 2008, but that was a long time ago. And that really just looked at saying on par, so that equal. Everyone gets a sneaker. You get a physical health, you get a mental health, you get addiction. Boom. And it really left a lot of gray areas in what that looks like. And I think that's where the over-medicalization and the insurance coverage conversation started. And instead of saying, how can we deliver this best and on par with it being outcome-based and having goals in mind and really looking at health, we started looking at, okay, how can we equate mental health, right, and physical? Okay, a surgery, okay, what does that look like in mental health? Okay, an LTAC, what does that look like? And we really were starting from backwards because the act itself really looked at coverage instead of looking at mental health as this kind of field that needed innovation. So I think it started a good conversation, but we have a lot of room to go to say, what does care look like? How do we prescribe connection? How do we prescribe, looking at IDD, what does that look like? What are the treatments? And we've come far in ABA. So I think legislatively, we really need to look at what we need to do next past MAPIA to say, okay, now that we are equal, how can we actually get to that equity piece where we're getting individuals what they need, whether they be 0, to 150 years old? What does that look like, right? If they don't need a medication, but they do need connection, what does that look like? And then go back to how do we pay for it after that, right? Instead of starting with, you have to pay for it. What does that look like? So I think we kind of had the conversation backwards, to your point, kind of even with the stigma conversation. So now that we know we have to pay for it, we got to get to the part of what does it look like and how much do we pay for it? Because that's a whole nother conversation, rate adequacy and having mental health services and providers paid what they're worth. I think that would really help with the workforce shortage, right? If I knew becoming a social worker, I could actually take care of my family, I might do that, right? If I knew, I wouldn't skip straight to becoming a doctor, right? Because that pays the most. I would say, hey, there's a lot of other things I'm actually interested in that I actually am passionate about, but I also want to make a living and be able to provide my children something. So I think we really need to look at putting our money where our mouth is in terms of mental health.
Yeah, I think you made like 3 really great points there, and I think the key is the focus, right? And I think, unfortunately, we take a one-size-fits-all approach to everything in mental health, and we're not really taking a step back. And what we're not addressing globally, I think, is, it doesn't matter what the treatments are. We have to find multiple different entry points for individuals to feel comfortable to engage with any type of treatment. And in our experience, what we have seen is, and we believe this, so if somebody engages and they have a good patient experience, we see that they're more likely to continue on with care when they're done with ours and engage on their own. And that's that empowerment piece. We have to find a way to empower people to take ownership of their own health care and know that they can get some type of care. And I think it's incumbent upon all of us, there's a moral obligation of everybody in this room that we can't just stand there and say, hey, here's the best treatment option and that's it. We have to be prepared to offer them multiple different entry points to get in that make them feel comfortable and ensure that they stay engaged and have a good experience. Otherwise, we're never going to get ahead of this. And what's interesting is when you look statistically, what I'm always kind of baffled by is we can talk legislatively, we can talk about all these other issues, but at the end of the day, if 67% of people who have anxiety disorders or depression don't even seek out treatment, that's where we have to begin. To your point, start at the bottom and work your way up towards the problem and figure out a way. Let's talk to these communities. Let's engage them in a way to get information so that they can tell us how they want to access care, what type of care they want to access, and what is going to be most compelling to them.
Yeah, so tons of incredible thoughts. I appreciate that as the sort of, so I didn't think I shared, but I'm about 3.5 years into the health plan space, right? So listening like
the evil empire.
Well, I didn't say that. And
Welcome to the dark side.
so I appreciate all the insights because it does, as I entered into the health plan space, healthcare ecosystem, sort of ask those questions about, like, why do we do it this way, right? And is there other ways to do it? And I think the idea of effective care for me goes to a couple of things. One is the idea of what are those entry points? What are the interventions? So we started a traditional healing benefit for our members, right? And we had to go engage in community, understand what that would mean. How would we pay for it? We were very transparent with the folks we were engaging with. Would this be a good place to start? We're trying to pilot it. We're trying to test it out. And we got that feedback. And they said, yeah, this would be a good place to start. How many could you cover per year? We said, could we start with 2, 3, 4? They said, let's start here. So we really had this back and forth. So the idea of effective care, I think, also has to begin with those who need it. And what are they saying would be effective? Yeah. And I think we don't do that a ton. Yeah. We simply sort of say, we've been in this business for a long time. Right. Typically, if we can get somebody to do 4 or 6 sessions, it works great, and they move. And the idea is, have we actually talked to folks to say what would be effective? And then the other thing I would say is, to me, effective also implies long-term and ongoing. And so many times in sort of the healthcare ecosystem, because it is about how do you pay for it, it becomes, if we don't see the benefit, if we don't see the decrease in a certain few metrics within 2 to 3 quarters, maybe it's not financially worth it to continue. And I think we're putting a financial metric of effective over a person metric of effective, which I think is also what we have to continue to sort of wrestle with as an ecosystem, is this idea of effective, and it's effective for who? Effective for us as an organization, effective for the member, right? We're a member organization, effective for outcomes, right? Ongoing improvement. And so I think those are some of the things that we have to continue to wrestle with and sort of, one, I think, be transparent with, seek connection, sort of partnership and community to create solutions that would go much longer and much further in terms of engagement, access, and outcomes.
Yeah, real quick, I want to take a brief pause and mention that we'll have a Q&A section at the end of this panel. And so if you have questions for any of the panelists, please scan that QR code, and we'll carve out a little bit of time to address anybody's questions from the audience. But thank you all for sharing that context. Really, really important, particularly when we're talking about the effectiveness. But I believe there's also a third component when we talk about breaking barriers. We talked about access, we talked about effectiveness, but there's honestly, I think, something else that is really important to this equation, and it's centered around trust.
Yes.
And that's something that we really believe in. And when Alchemy was founded, it was founded under a core belief in a pretense of like, look, we need to build trust and relationship with a community that has been marginalized, underserved, mistreated, abused, misdiagnosed for 400 plus years. And so there's a lot of work that needs to be done just to repair the relationship and build trust. And so can you all talk about like how your organizations are respectively building trust with the stakeholders and patients that you serve?
Do you want to start at the other end?
Okay, all right. So I think I mentioned it a little bit, this idea of sort of engaging with folks who are experiencing the inequity. One of the things we talk about at Blue Cross is community has the answers, right? And so many times we have tried to sort of fashion the answers from inside, take it out and say, hey, isn't this great? And I think part of what we're doing differently is going into community to say, those who need an intervention, like what would it take? What could it look like? And we're being transparent about here's what we can and can't do. So I think one of the things about trust is we haven't laid our cards on the table. We have said, hey, we're coming to help you, right? Sort of in a savior mentality. We're coming to help you, and here's how it's going to look. Yes. Instead of saying, like, we are in a system, right? Like, that's just what we are right now, and that system has certain things we can and can't do, and here's what it looks like. And so here's what we can do within that system. I find that if you approach folks and provide those sort of data points, that information, that perspective, and they understand that you are trying to work towards an ultimate end, I find that builds a little bit of trust to say, hey, they're coming to me, being transparent, saying, here's what we can do, here's what we can't do. So when you ask, like, why aren't you doing that? I can be really transparent and say, hey, like, CMS says we can only do this and this and this before we're out of compliance. So maybe there is this legislative, regulatory thing that needs to happen if we are to build trust. I think the other thing that we're trying to work on in terms of building trust, and it's been stated a couple of times, and that is simply acknowledge the history. Yes. I think our system is built on, frankly, the exploitation of a number of marginalized groups. And if we aren't just being upfront about that and acknowledging what we say is our being complicit in that, and now our work to move beyond that and be part of a solution, I think that's also important, right? If you have harmed someone and you're trying to build trust is never built if you never acknowledge the harm. Right? You're trying to be transactional, and we're trying to be more relational. So that's what I would say is some of the ways we try and build trust.
So I just want to thank Bukata for being so refreshingly honest, and I completely agree with everything you're stating, and I think that's the right approach. And what I love that I heard you said was you're going out and trying pilot programs to get people to engage, but you're listening to them. And I think the acknowledgement of the past, the pain, and the missteps that we've done, especially around individuals with mental health, is really important. You know, our approach has been, it's very interesting. So we take the patient journey experience very seriously at Free Spirit, and one of the things that our marketing team always wants to do is they want to go out and do market research and understand the patient's behaviors and understandings. And frankly, I said, I don't think we know the right questions to ask yet. More importantly, though, we have the greatest opportunity and the greatest database alive of any company in our sector because we're engaging with patients every day. Let's just start talking to them. And how we're building trust is we're asking very specific questions. Our coaches build every patient that goes through our program is paired up with a care coach that guides them through the 28 days. They're not practicing medicine. They're really their partner on this journey. But through that, this trust that's built because they feel they have somebody that's helping guide them is really important to them. We're getting information from each of the patients that go through that we can build a better patient experience. And what we've learned about trust is it actually goes just beyond some of the things that Bukata was talking about here, but more importantly, different lines of businesses. So, we're finding that the way you message to different genders is very important to individuals. So gender preference messaging is important. Lines of business and community messaging is very different and very important. The way you communicate to a veteran is very different than even the way you would communicate to an active military patient. So all of these components are really important for us, and it goes back to if you're going to build trust, then let's get the right information. And then as we go back and we're engaging and we're training our team, so the minute an individual reaches out and engages with anybody from Free Spira, they are armed with up-to-date information to say, great, you're a veteran. Here's what we're hearing from other veterans that went through this program. Oh, you're an individual in this culture, so let's get somebody on the phone that speaks your language. If not, we have a translation service, right? Let's try to find somebody culturally that is similar in nature to what what you want to experience. All those pieces are important, but you have to start somewhere, and I think it's oftentimes gets lost. We're trying to tackle the entire problem and find a solution for it. Let's just start by tackling it one issue at a time, and I think we'll eventually begin to build trust, and people will recognize that we're making an effort to have an impact that's going to benefit them.
I love that. So I think being a person that sees patients still, it really humbles me in my day job. I like to call my day job. So what my side job has taught me is that I have to start with understanding what the person in front of me wants. And then really that's society as a whole. But in this context, I start with them. Like, what do you need? What are you looking for? Before I do that over-medicalized H&P I was taught, right? Like chief complaint, like all that. I used to start with that earlier on, and it got me nowhere. I was kind of trying to piggyback them into a box. It was almost a mental algorithm I was taught. And I've thrown that out the window. I literally am like, what are you? And one thing about working with teenagers is they will tell you, like, oh, why do you look bad today? Are you tired? What's wrong with your hair? I mean, they keep you, but another thing they'll tell you is, oh, I'm not going to take your medicine. But I've spent an hour talking to you about your medicine, and your mom told me, oh, they're like, oh, yeah, I'm not taking that. And I'm like, what did I just do for an hour, right? So I start there, like, what are you looking for? How can I help you? How can I be a partner to you? How can I collaborate? What do we want to do together? And it can't always be what I think they need, right? Or what I know the research and data shows. It has to be a collaborative partnership, and that's where the trust starts, I've even let a couple inappropriate words slip, and they've been like, oh, you can't say that. I'm like, oh, my God, I can. It's not against any law, And so I think they see you as a human. People think, oh, doctor, right? Oh, my God, I've never seen a doctor. And I humanize that, and it's a partnership. Like, you tell me what you need, and let me see if I can help you with that. And then I will tell you what I see, right? And what I think, and let's see if we can meet somewhere in the middle and start this journey long term, right? Because mental health is rarely 6 sessions, even though TikTok will tell you can break up with your anxiety in 60 seconds, right? They didn't tell you you're gonna get back together, right? So I think mental health, yeah, right? They're like, oh, yeah, we broke up for a minute and now it's back. So I think really starting that paycheck, and I brought that into my team because what my team was doing, oh, I learned how to do a person-centered thing this way, and no. Did you ask them anything about their life? They just had a child. Are you tired? Are you hungry? Do you have meal? Like, start with them, and then you can get what you need. You can check off the compliance pieces and do the pieces we know CMS tells us we have to do. And then you really learn how to partner together, what they need, what you need, let's do it together. And then we can figure out, do we need to start a pilot? Are we not able to meet what people are telling us they need, right? Because I hear that a lot. Like in the mental health community, especially maternity, they needed doulas certified in mental health. And we didn't have that benefit. So we started a pilot, to do it. You could spend money if you, think you can make it back. And so you have to be flexible and adaptable and humble in mental health, because there's nothing like a patient telling you they didn't take the meds all month and coming back like, oh yeah, I didn't know I was supposed to take it when I left. I'm like, I called it in. Like, it's just these little things that okay, all right, take it starting today, right? Like, what were you waiting for? So you really have to understand the person and build trust with you, and then address those systemic trust and those barriers and be honest. Like, I know we haven't had the best experience in healthcare in this country. No one has. It's fragmented, it's confusing, it's expensive. And so really just saying, hey, how can we navigate within this one person at a time, and then take that to the system level, I think is really important in building trust in healthcare.
I don't know how to follow that. You said everything that was on my mind.
I felt the same way about him. I'm like, why don't we go backwards?
But I guess I'll just say that I agree with all of the comments around, designing patient experience intentionally for what the patient actually needs. I agree with the collaborative care comments, making sure that patients have a say in the process of what is being delivered to them with the provider. And I think at the end of the day, the lack of trust comes from a lot of patients not feeling seen and heard by the system, by the providers. And I think therapeutic alliance is a very important measure when it comes to culturally responsive care, making sure people feel seen and heard by their providers. And so we do measure that at Anise, but we're thinking constantly of ways in which we can kind of improve that therapeutic alliance by equipping our providers with the right information so that the patients feel seen and heard. So we've adapted kind of every step of the journey to collect the right information. So even the intake process, we're not just asking them for, okay, like which ethnicity therapist do you want? We're thinking about the whole person. We're thinking about their religious background, their gender, their sexual orientation, the language that they need, their generational status, all of the different things that make someone who they are that might be critical to acknowledge in the process of delivering care. Collect all that information. We use that data to recommend the right providers for them. And then we're transparent about that data as well. We have built an index called the Cultural Impact Index that allows both our patients and providers to understand where there might be elevations in cultural stressors. So not just the PHQ and the GAD, which frankly might not explain like why someone has anxiety, why someone has depression. It helps dive into things like perfectionism. We measure a culture of stress. We measure one's sense of belonging to their home versus heritage culture. And then the patients can see, some of those measures themselves, and the providers can see that as well, and they can talk about it because all of that is shared transparently across everyone on the care team. And when you start to see an acknowledgement of those things that are core to who you are, it helps to make the conversation also feel more natural, more humanized, and you start to feel that alliance form, which keeps you engaged, which then allows you to see improvements in clinical symptoms over time. So yeah, I think fundamentally fixing that trust issue comes down to just helping people feel seen and understood, and the more we can do to be transparent about the data that goes into that patient-provider relationship, I think is one step that we've taken at Anise.
Yeah, and I would be remiss if I didn't mention, just off of Nisha's point, feeling seen and understood. To me, that really builds up to like brand and how you show up for folks long before they enter into the therapy room or see a clinician. But like the look, the feel, the language, the representation in the marketing collateral, so on and so forth, the community building experiences, the touch points, all those things really matter long before someone enters into a therapist's office. And that's something that we've really prioritized over a number of years, particularly for marginalized communities, and especially in the Black community where the conversation has never really been had. Mm-hmm. And you can't even see yourself in those clinical settings or in that hospital system because the marketing, the collateral, the brand is not even designed for you, so it's not even on your radar. And it feels very sterile and it doesn't feel warm. And so all these things and all the panelists' talking points have been very, very important, particularly around like building that trust point. And so now just jumping into a few of the questions from the audience. This one can be like a rapid fire. So we'll just go down the line and give me a quick one-word answer. And I'm going to paraphrase this question, but how do you know the needle is moving in the right direction?
If I truly have to give one word,
Yep. Rapid fire.
engagement.
Yes. You stole my word. Oh my goodness. I think trust. Trust really gets you far, so that they're showing up. So it's kind of engagement, but different levels of engagement.
Adherence.
I'm gonna use a hyphenated word or three. I'm gonna say like self-reported sort of satisfaction, right? This idea that like some ways you measure it is that people tell you that it's a better experience.
I like satisfaction.
All right, next question from the audience. Do you all have any thoughts on practical policy-based changes that would make a significant impact in enabling the development of high equity solutions?
So one that I would mention, and we had talked about it in prep, and I think this is part of a sort of policy change, would be sort of, I think right now we have some blanket sort of, and I'm talking from the health plan world, codes about source of mental health manifestations, right? And so, for example, if we're talking about mood disorder, anxiety, depression, like what's the source of that? Because the treatment based on the source would be different. So for instance, if it's financial stressors, and that is what's triggering anxiety, there's a different sort of treatment based off of that. If my mood disorder or anxiety is because, so myself as an African American, I live in an exclusionary world, it's a very different treatment, right, based off of the source of that. And so for me, the policy change would be around identifying that source, because I think we're able to identify better treatment, engagement options post a differentiation of the source.
I love that. And you actually triggered kind of a further thing. I think we need to redefine primary care. What does that even mean, right? Like, it's first, right? Like, so I get, we're talking prevention. What does that look like in mental health? You know, what is the immunization form of mental health prevention broadly? Like, how do we prevent these problems, and how do we get paid as providers in that landscape? You know, if we're doing things that we think maintains wellness, that should be translated into a policy that it fits into this quote-unquote medical model, because no longer is just going to one kind of doctor that checks off different boxes primary care anymore, when mental health is just so obviously impacting the full body. Like, I don't even know if I'm a primary care provider or not. Sometimes it is, sometimes I'm not. As a psychiatrist, they're like, you're kind of, but no, because you have a problem. But, you know, therapy, I think everyone needs therapy, you know? So we could all use a little bit. So does that make it primary care? So I think we really need to have a standard definition of what is primary, what is prevention, how can we expand the providers that is inclusive of that, and then how do we shift to paying and the money going towards prevention and keeping folks healthy mentally, physically, spiritually, socially, and then if we have to pay for the other things down the line, then we can do that.
So I love what you're saying, and I'm going to take a different approach, and I think we have to look at the reimbursement piece. I mean, we have to acknowledge that the government is very slow to reimburse any novel treatment that comes along. So I think if they wanted to, you know, increase the rigor necessary to get approval, that's fine in many ways, but I think there has to be a partnership between FDA and CMS so that novel treatments come out, maybe a 2-year program where we're going to fund this temporarily for 2 years. At the end of 2 years, we're going to look at the data. And if it's working, great. If it's not, we're not going to reimburse it any longer. But that's the only way you're going to get the movement necessary. Because, I mean, right now, mental health patients are really disadvantaged because over 60% of the cost, over 60% of the services they access are out of network, which means they're paying for that all out of pocket. It's an unfair burden that's placed on those individuals. And again, it goes back to very specific communities are impacted disproportionately, and it's just not fair.
Nisha, you have anything? All right, it's a wrap. Well, I want to thank everybody for your time and attention and engagement in this discussion. Thank you to the panelists for your insights. And please today, take good care of yourself, take good care of each other, and take it one step at a time. Thank you all, and enjoy the rest of the conference.